On this episode of the ASC Podcast with John Goehle, we discuss the latest news and information from the ASC industry, including updates on the flu and COVID-19, and a discussion of supply chain cost increases. In our focus segment, we interview Bill Prentice from the ASC Association.
Welcome to the ASC Podcast with John Goehle, the longest-running podcast specifically focused on the freestanding ambulatory surgery industry. We would like to thank our sponsors, Surgical Information Systems, providing cutting-edge information solutions for surgery providers. Trivalence. Trivalence offers a comprehensive next-generation ASC solution that optimizes payment and supply chain performance, enabling actionable data insights. And Ambulatory Healthcare Strategies, the nation's leading regulatory and accreditation compliance resource for ambulatory surgery centers. For more information about our sponsors, please visit our website at ascpodcast.com.
Welcome to episode 168 of the ASC Podcast with John Goehle for October 10th, 2022, recording from our studio in Spencerport, New York. This is Sue Cronkite, Chief Researcher for the ASC Podcast with John Goehle and Senior Nurse Consultant for Ambulatory Healthcare Strategies. The ASC regulatory environment is extremely dynamic, and the material provided in this episode is based on information available as of the date of recording. Joining me is John Goehle, the owner of Ambulatory Healthcare Strategies. He is recognized as one of the nation's leading experts in the ambulatory surgery industry. Mr. Goehle is the author of over 10 books on the ASC industry and a frequent industry speaker on regulatory, accreditation, and finance issues.
So we have been busy going to conferences. Sue, you and I were in Ohio, then we went on to New York.
Yep.
Previous to that, I was in California, and we have special episodes for each of those conferences. Then we have one of our employees going down to the New Jersey conference next week, and then I'll be heading out to Massachusetts and then Washington State. So
Yes.
We're going to be very busy, and we have to see if Massachusetts and Washington will give us some material to be able to do podcasts from there. But I'm looking forward to it. I've been to Massachusetts. I've never been to Washington State. So we'll see how that conference goes. I know it's a pretty big event, so I'm excited. And then our boot camps. This is the first time we've ever announced both the administrators and director of nursing boot camps simultaneously. The conferences are not simultaneous, but the director of nursing boot camp will be in October, and the next administrators boot camp will be in January. And Sue, that January boot camp will be celebrating our third anniversary of doing that. So I can't believe that it's hard to believe that we're 2.5 years past the pandemic now. So I think we're still getting adjusted to that. But the boot camps have been very popular, and we are very happy to see them continue. And I think both of us kind of thought that might be something that wouldn't keep going on after people got back to real work. But I think it's actually given it more of a push because people just can't get away in today's environment.
Yeah, and I think there's still so much turnover that there's always new people that need to learn just the basics of the job and dig in a little bit more.
And we're still working on our business administrators boot camp or business office managers boot camp. I don't know what we're going to call it yet.
Yep.
We're working with Christina Benton on that, and we just haven't been able to nail down a time yet. But that will probably be our target right now is in the fall of 2023. So that is a bit away off. And Sue, we celebrate this week Sterile Processing Week. I kind of feel bad for making a big deal out of it, not because it's important, but we never really celebrate any of these important weeks. And I think I just happened to see this one, or actually it was brought up to me by Lori Rodericks, who's our infection control expert.
Not because it's not important.
That's right. It is so important. Yes. And if anything,
absolutely.
What a group of people that probably don't get a lot of attention. But we promise we'll try to celebrate everybody. But this is an important week for you to go and I don't know if this is appropriate, but go and hug a sterile processing person. But
ask permission first.
Right?
Just don't go jump. But no, I mean, I think for people that are so out of the public eye that aren't really right in your face all the time. They have such an impact, though, on patient outcomes, that it really, they deserve a lot of appreciation.
Yeah, and it is a tough work, and it's, we, I know you and your training as a nurse, didn't get really much sterile processing. Yeah, sterile technique, but you didn't get any education on sterile processing, and certainly myself, I had a 40-hour course on it for my training accreditation surveying, but I got to tell you, at the time that I took it, I'm not sure I understood half of what was going on. Probably should take it again because I think I've learned so much from it. But then again, working with Lori has been fantastic. She's really explained a lot of it. And of course, if you want more information about sterile processing, you can certainly look into our Infection Control 101 and 201 courses, which are available on the ASC Podcast website. Sue, another thing that we really enjoy every week is our drop-in sessions for our patrons. Again, I want to thank all of our patron members here. We have over 100, I can't remember the number now. It's over 150 of them. And, anybody that attends one of our boot camps automatically becomes a patron member also, as well as those that sign up individually on the ASC Podcast website. So definitely one of the biggest advantages of that program is that weekly drop-in session where you get to ask all kinds of questions. And last week, Sue, we had 4 surveyors on again, 3 health surveyors and 1 life safety surveyor. So a lot of questions going after that poor life safety guy, but he enjoys it. So. Okay, well, let's talk about the latest news. We haven't done an episode with news in a bit, but it really hasn't been terribly busy. I think we should knock on wood about that. But let me start off with ASCA recently did a survey that looked into increases in drug and supply costs. And I'm going to give a link to this. There is no surprise about this at all. What they found is 100% of the respondents shared that the prices of medical items and equipment have gone up in the past year. And 99% of them stated that prices of medical supplies and equipment had increased over the past year. Just one multi-specialty facility in Pennsylvania reported a decrease in prices. When asked about the magnitude of the price increases, 61% of the facilities estimated that the increases were between 10 and 24%.
Wow.
Which is pretty incredible, especially when you consider that the proposed increase in the Medicare rates for 2023, based upon the CMS initial proposal in July, is 2.7%, which is certainly not going to make up for these increases. So we're very concerned, obviously, about what's going to go on. Also, that same study indicated that the biggest increase was in lidocaine on the drug side, which, if you think about it, that's a drug that's used in, I would say a vast majority of surgical procedures in some form. So let's keep an eye on that and see if the supply chain continues to be a bit of a problem.
And, you think about that's even if you can get these things. So it's not just the price, it's the actual supply. So it's it's worrisome.
Yeah, and definitely you probably should be stocking up on it. I hate to overstock this stuff.
Don't hoard it.
Don't hoard it, please. But you should be stocking up on it because it's probably not going to get better anytime soon.
Yeah. So I just looked into some COVID data on the CDC site. Right now, it's pretty good news, although I think that probably the cases will start going up again. But we'll put the link in for the CDC site where you can look this up. You can look up U.S. totals and also, specifically by state. So the U.S. totals in all areas were declining when you go from the last 7 days to the previous week. So there's 488,798 cases, which is down by 21% from the week before. The viral or PCR lab test positivity is 13.5%, which is down just 0.2% from the week before. Confirmed COVID-19 admissions are 30,772, which is down 15.8% from the week before. And deaths were 2,397, which is down 19% from the week before.
That's still, if you take that number, 2,397 for a week, that's still significantly, that's still a significant rate right now. So.
Yeah.
It's great that it's down that much, but boy, it's amazing that the numbers are still that high.
Yeah, and we are, of course, going more into the winter time. And there was again, we'll put this link on there to hospital utilization. HHS Protect Public Data Hub is where you'd find this, but we'll put the link on there. And you can search any state to see the hospital bed availability, which is both the inpatient and the ICU beds. And I just for example, in New York State, they said 73.2% of the ICU beds are currently in use. So at least it's a whole lot better than it used to be where everything, which is why I looked up New York State, because I know, especially in the city, that we were over capacity for quite some time. But only 5.6% of those are being used for COVID patients. Yeah, and when I looked at a few other states, it was right around that number in most of the states. So it's not as though COVID is filling up the ICU beds anymore right now.
It is sad that we still have such a high occupancy rate, though that is it's certainly better than 100%. So. Yeah,
and I don't know if there are still issues with gathering data when you look at, with COVID versus from COVID and that kind of thing. But, the numbers themselves do look better.
Well, and I guess we better go back and talk about the flu too, right?
Of course. Yep. And of course, the flu season, at least in New York, and I think probably, I don't think it's been declared anywhere that I'm aware of, but may have been. So on the CDC surveillance report, they, first off, strongly recommend you get the vaccine before the end of October. You really probably should have gotten it by now, but and if you don't, any time that you get it is better than not getting it at all. But certainly, if you want to really be protected, you'd want to get it very soon.
And both Sue and I got it together.
We did.
It was not painful. I didn't run away from the pharmacist.
Nope. The peak of flu activity is between December and February, with February has historically been the worst month. I think 17 out of the past 35 years, February has been the worst. On the U.S. map that tracked the rate of influenza activity, which is weird, but only Texas, D.C., the Mariana Islands, and Georgia were in the high category. So it's kind of hard to explain. Yeah. I don't know if it's the way they're gathering data. I don't know why those random places would,
that is weird.
That aren't right together. But everybody else was either lower or moderate. So that's good. But you kind of have to keep in mind that we've become a lot more relaxed about the flu because we were focusing on COVID, and the last couple seasons were very, very mild. It barely registered at all because we were all, doing the COVID precautions, masks, isolation, hand sanitizer. And so people just weren't getting the flu. So there's a lot of concern that now our immunity is going to be so far down. Little kids, like 2-year-olds, probably have never been exposed in any way. So, there is some concern about that. Now, the Southern Hemisphere is where you probably all know where the flu season starts, and they say it's being hit really hard this year. And only 66% of adults over 65 in the U.S. actually have received the flu vaccine last year. So we're hoping that people are going to kind of become aware that it's probably going to rebound quite significantly this year. And don't forget, it's, we've been so focused on COVID, but flu can do a lot of damage itself. So just encourage everybody to be more aware of that.
And Sue, when you saw this next article, you were quite concerned about this impact of short-sighted. Fascinating little notes. So.
I know. And I guess anybody who has an eye center, maybe it's some hints you can give to your patients. But I was surprised to see this. It was an article in the BBC Family Tree. It's an online, journal or something that they put on there from October 4th of this year. And they said 40% of adults in the U.S. are short-sighted as compared to 25% in 1971. And the rates among teens and young adults in places like South Korea, Taiwan, and mainland China are between 84 and 97%. That is crazy to me.
Yeah.
And at this rate, they said half of the world's population they would expect to be short-sighted by 2050. Although obviously, people think, well, you just wear glasses, and probably anybody that works in an eye center, or you, John, probably knew this better than I did, but it can eventually lead to more serious visual impairment, cataracts, retinal detachment, glaucoma, so even blindness. While genetics obviously play a role in this, the research is pointing to spending so much time indoors and reading and working at close range, so computers, even reading, which of course we want to encourage education and kids to read, but doing it almost like if they could sit outside, because it's really, they're finding it's at low light, not being exposed to the natural light, not looking farther, like when you're out taking a walk or whatever. And in one area in China, they found that the rate of short-sightedness in 6-year-old children increased during the first couple of years of the pandemic from 5.7 to 21.5% in just those 2 years of the pandemic. So who knows what has happened other places just because everybody's kind of been locked down. And an interesting part of this is that the middle to lower income populations tend to actually have lower rates. And the higher socioeconomic status is correlated with short-sightedness, and often those children, you figure they're spending more time in school, they're getting lessons, maybe piano lessons, doing other indoor activities, but it's going to end up being a problem because especially if you get those more serious eye issues, you're going to be struggling as you get older. So it was just something that I wasn't at all aware of. I found it interesting.
Well, if you think about how much time we spend in front of a computer, I mean, this is making me think about today. We're recording this at 3:50 in the afternoon, and I've been on the computer since 5 o'clock this morning. The only time I leave, of course, is to cook food, which is my other important thing in my life.
And even when you're thinking, because even if you're not looking at a screen or watching, it's not that the kids are necessarily sitting in front of TV all day, but if you're in the house, you're only looking as far as that wall across the room from you. Yeah. And also they really stressed having to do with the natural light. So some schools and some other countries are trying to just have more windows, maybe have like sunroofs, but then there's that whole comfort level of trying to read in really bright sunlight. So they're looking into trying to figure out what to do, but
maybe we need to move our studio up into our sunroom, which is the one room in the house that's used the least, right?
I don't know, but then we'd be staring at the computers in front of us reading our screens.
That's true. That's true.
It might help a little, though.
So, Sue, let's talk a little bit about some of our recent experiences. One thing, this is kind of amazing to me, that it's happened 3 times in the last 7 days.
All of a sudden, it's crazy.
So we've had suction machine backup problems. So 3 of our centers in the last 7 days, one pretty serious where the backup pump was not working. They had to kind of shut down surgery. Well, not kind of. They had to shut down surgery because the backup pump was not working. It was not the pump itself that was a problem, but it was the board that controls that pump.
So that automatic switch on when the other one fails.
Correct. So that was an ongoing problem. And then, I went off, did a mock survey at one of our centers in Manhattan, and I'm looking at there, and, sometime during the day, I mean, they double check these things all day long, but when I went in, the pump had shown a failure. So I notified them and said, you have to do something about that pretty quickly. So one thing to do on a daily inspection and document this is your review or your checking of the status of your 2 suction pumps. So for those that don't know, the suction pump machines always have 2, sometimes 3 pumps. I guess it's possible to have even more than that, but the average surgery center has 2 or 3. And then what happens is the suction pump tends to work off the suction for the facility tends to work off of or works off of one of these pumps and then switches periodically to the other pump. And there's always that backup capability. So if one pump goes down in the middle of its operation, it should automatically switch over to the other pump. But you should always, just like with electricity, you should always have backup resource for suction, given how important that suction is in a surgical center. So double check that, make sure somebody is checking that every day, and follow up immediately. And if your backup is not working, you really are in a situation where you shouldn't be doing operations. Second thing that's been coming up is we've had a number of clients that have come to us about wanting to do research. In other words, patients were coming in that were part of a research project, or they were themselves going to be running a research program. So I have quite a bit of experience with this, and I just led them through it. But basically, just kind of a quick overview. The governing body obviously has to review the contract or the agreement with the research organization. The research has to be approved by an institutional review board. That's an IRB. Generally, that's an external board. Can't imagine most surgery centers are large enough to have their own. And the biggest part of the institutional review board is making sure that the patient has a proper informed consent. So all of those things have to come together. This is one of those things that surveyors look at when they do a survey. So there's a whole chapter in HHC, for example, for research. And what we're expecting to see is the governing body overseeing that program, reviewing the contract, reviewing the IRB report, and then making sure that there's some that there is a copy of a signed informed research consent in each of the patient's charts. And lastly, for recent experiences, doors, Sue. We went into one facility that in the last 2 months since I visited, the doors were in terrible repair. Yeah. It's amazing. I don't know what was going on here, but the doors, those with automatic door closers, they won't close all the way and latch. There were holes in the door. Some of the doors had, tape over them, holding the door open. So remember, so one thing that is required under for ASCs is they have to do annual door inspections for any of those doors that go through smoke or fire barriers. By the way, we do, and it requires training. Now, you can hire an outside company to do it, but it isn't actually required for you to hire an outside organization. With proper training, you can have somebody in your own organization do it. And as luck would have it, the ASC Podcast with John Goehle has a training program for that that's available for all of our patron program members. It's also available for purchase from our website at ascpodcast.com, but most people tend to do it through the patron program. So it's a free educational program, and you get a certificate at the end of it. But if you'd have to sign up as a patron member. But here's my point about that annual door inspection. It's not just because of inspections. Those doors are very critical elements of your life safety in your organization. So make sure that they're kept in good repair. You can't have any holes or damage to the doors. You should replace or repair them. Most of the time, they actually have to be replaced. And then also, in addition to any of those, just make sure the hardware is all working, the locks, the latches, et cetera. Yep. And while we're at the subject, let's remember and remind everybody to check your smoke and wall penetrations. It's the easiest thing for a surveyor to cite, a life safety surveyor to cite, and it's also the easiest thing to fix. But it's one of the things that you will find many, if not almost all, life safety surveyors citing during an average survey. So.
Especially if you've had some work done recently, right? Or like IT things, putting wires through.
Those IT people, they seem to always love putting holes through your walls, and they're kind of sneaky about that too. They
probably have no idea that it even matters to you. They just pop those wires through, and the next thing you know, you're getting cited because you got holes in your walls.
That's right, and that I do find, as a matter of fact, as you said, Sue, that's actually I'd say 90% of the penetrations we find are because of IT. Because obviously, there's so much IT work being done in the average surgery center today. Okay, so that gets you up to date on recent news and recent experiences. Let's take a short break, and then we're going to come back for an interview that I did during the California State Association meeting in September with Bill Prentice. Now, Bill is on the podcast periodically. He is the executive with the ASC Association, and this time we talked about recent events going on with the ASC Association, as well as a discussion of the proposed 2023 CMS regulations and payment rule. So let's take a short break, and we'll be right back. It's been a long day, and the surveyor's just left, and you are exhausted. And looking at the list of items that you have to address, you wonder, how can I deal with this and still take care of my patients? More importantly, you wonder, how can I ever keep up with all of the regulations, standards, and accreditation requirements? How can I always be prepared for a survey and reduce my stress levels? Well, that's what Ambulatory Healthcare Strategies does, day in, day out. We become your outsourced regulatory and accreditation resource. We can maintain your policy manual, develop your education programs, help out with fire and disaster drills, do your risk assessments, oversee your quality improvement activities, help run your quality improvement meetings and governing body meetings, and we can even prepare your monthly or quarterly financial statements and help you figure out where you are financially. We are a retainer-based service. We don't take ownership. We don't charge based on your revenue. We have one fixed monthly fee, and we can tailor your services to your exact needs. So whether you're looking for help getting over a survey, preparing for a survey, or looking for a long-term relationship to assist you with your ongoing regulatory and/or financial needs, please give us a call at 585-594-1167 or email us at info@ahstrategies.com. That is info@ah-strategies.com, or visit our website at ah-strategies.com. So I'm here at the California Association meeting in September of 2022, and I'm here with Bill Prentice. He's the Chief Executive Officer at ASCA. And Bill joins us a couple times a year. Thank you, Bill, for coming on the podcast here, talk a little bit about what's going on. Last time you and I spoke, it was before the new payment rule for 2023, the proposed payment rule came out. So can we start by talking a little bit about, what were some of the major events or things that came about in the proposed rule?
Well, thank you, John. It's always a pleasure to spend a few minutes with you and talk about what's going on in the ASC space. When it comes to our proposed CMS payment rule, Medicare payment rule this year, the usual buckets. What are we going to be reimbursed? How are we going to be updated for inflation? What procedures are going to be added to our list? And are there going to be any significant changes to our quality reporting program? Taking first things first, when it comes to payment, we're a bit disappointed in the inflationary update that's been proposed. Only 2.7%, for both us and hospital outpatient departments.
Especially in light of all of the dramatic increases that we're experiencing, especially in salary costs or wage costs.
Yeah, exactly. I think we all can see the impact of overall inflation in our personal lives.
Yeah.
And since most, generally medical inflation is higher than overall inflation, a 2.7% increase seems, way too low. So we're obviously going to be advocating for a fresh look at that data and hoping that we get a higher inflationary update by the time the rule is finalized in November.
And you and I were talking before we started the recording here. I've been around a long time, actually in the industry longer than you. And I remember in 2008 when...
Stop bragging.
I know. I don't think it's bragging. In 2008, when we moved to the new reimbursement system, there was a lot of talk about the importance of us being tied to the hospital system. It seemed counterintuitive at the time, but I think we're running into that same situation right now with this the payment rule update.
Yeah, for listeners who have not paid close attention to this, a reminder that this is the fifth year of a pilot program where CMS has been updating ASCs for inflation using the same inflation factor as the hospital outpatient departments, the hospital market basket. Right. Before that, we were being updated using a broad inflationary factor called the Consumer Price Index for urban consumers. And most years, that CPIU would spit out an inflation number that, as I mentioned, would lower than the hospital market basket, again, because medical inflation generally runs higher. This is one of those odd years, though, where probably if we were on the CPIU, we'd get a higher inflationary update than what has been proposed using the market basket. I'd argue, though, that because in most years that is not the case, and because I think being aligned with the hospitals in terms of having an interest in having the best possible inflationary update, having their lobbying power, their market power, working on our behalf in this, to this extent, to try and get a good inflationary update, we're better off staying on the market basket. Right. As I mentioned, this is the fifth year of that pilot, so there is a chance that next year we could be revert back to the CPIU or something even worse, a change CPIU, which is a number that spits out even a lower inflationary number. We're arguing, of course, that because of the pandemic, the last 2 years, volume numbers are suspect. Right. And as a result, they really need more data about this pilot, so they should extend it for at least a couple more years and hopefully extend it permanently, something we're also trying to get addressed legislatively.
And I think another piece of good news right now is that we know the hospitals are not any happier about this low increase as like us.
No,
they'll make a big fight for it.
They have been very outspoken in terms of their concerns about this number, and so to the extent our combined voices through our comments to the proposed rule and things that we're saying publicly lead CMS to make a change and increase that number, I think we'll all benefit, and our patients will benefit as well.
Right. One of the challenges that I think we have right now, one of the things that we've noted, ambulatory surgery centers, we know are a lower cost alternative. Our reimbursement rate is considerably lower than the hospitals, built right into the CMS system. So we've always been making this argument that it's a cheaper place to go. But there has been a bit of a problem with that with regard to the Copay Cap. Now, we've talked about this before, but I think it bears repeating the importance of moving this. So why don't you talk a little bit about what that is and what we're doing to try to fight it?
Yeah, the Copay Cap is something that is a complete head scratcher to anybody who spends a couple of minutes thinking about it, which is the Copay Cap is a law that basically limits what a Medicare beneficiary will pay as a copay when they receive care in the hospital.
Right.
And so for this year, that's $1,556 is the maximum amount a beneficiary would pay. I think I have that number right. Meaning that it doesn't matter if that procedure you're getting in the hospital costs $30,000 or $40,000, you're not going to pay more than $1,500 some odd dollars as a copay. There is no copay for care being provided to a Medicare beneficiary in the ambulatory surgery center.
There's no copay cap.
No copay cap.
Right.
So what that means is that there's this perverse disincentive now for a Medicare beneficiary where it will cost her more out of her pocket to get a lower cost procedure in a surgery center than a higher cost procedure in the hospital. Yeah. So we as taxpayers are being disadvantaged by this perverse disincentive. Right. So we're looking legislatively in our ASC legislation to create a copay cap for our setting as well. Right. And this matters because, when the original copay cap was established for the hospitals, that was before ASCs were really performing high-cost procedures like total joints and spine procedures with high device costs. Now that we're doing more of those higher-cost procedures, this copay cap has really self-identified itself as a real barrier to care for Medicare beneficiaries that we need to address, particularly those Medicare beneficiaries that don't have like an additional Medigap coverage. Right. So this is the lower income Medicare beneficiary, more likely to be a beneficiary of color that is going to be disadvantaged by this barrier, and something we need to get Congress to address.
And we need to make it clear we're in favor of the cap. We just want to make sure it's applying equally to the hospitals.
Exactly. Look, we know that the cost of medical care, particularly for Medicare beneficiaries, is a real stress on them, and so we need this copay cap to apply both in the hospital and the surgery center.
Another thing that was interesting in this most recent one, when I read the proposal, the 2023 CMS proposal, that only one procedure was added this year. Probably I'd have to go back and look at my records, but I think it's the lowest number of procedures added in certainly recent history.
I think that's the case, and we actually had offered up 47 different specific procedures that we believe could be safely performed on appropriate Medicare beneficiaries in the ASC setting. So to have only one of those procedures being added is really just terrible,
especially post-pandemic, when we know that there's a movement already, and especially in other insurance companies from the hospital into the surgery center.
Exactly. And when you see what is moving on the commercial side, particularly in patients near Medicare age, and the things that we're able to do, and so total shoulders, total ankles, there's a host of different procedures that we could be performing that we really need to get added to our list. Right. One of the things that we've seen in this proposed rule, as well as last year's, was a really odd term being raised by CMS, which is the idea that a procedure has to be safe for a typical Medicare beneficiary in order to be safely put onto our list. Since there's no definition, we don't understand what they mean by a typical Medicare beneficiary. That's, we're basically fighting a ghost there, as well as the fact that just goes, completely ignores the whole underpinnings of the ASC model, which is that we use patient selection criteria to make sure that every patient that comes into a surgery center is safe and can be safely seen there, that they don't have comorbidities or other health conditions that would create a higher risk to receive care in an ASC.
And to take the pressure off the hospital so they can focus on the more intensive patients.
Exactly. So this straw man of this typical Medicare beneficiary is something that we need to get them to do away with, because it really doesn't make sense, and I think is really harmful to the growth of the Medicare program and to the ability to use the ASC to save billions of dollars a year. Right. Just to remind people, the fact that we exist as a site of service in the Medicare program saves that program over $4 billion a year. $4 billion that can be used to provide care in other ways and in other settings. So why CMS is not more incentivized to try and drive volume to our setting and increase that number, to create greater savings in the overall program that can be used to provide other benefits and other care in other ways, mystifies me.
And lastly, I think something that both you and I are very passionate about is the leadership challenges that we're dealing with, right? We have a staffing challenge too, but that's a discussion for another day. But what we have found during the pandemic is a lot of retirements of senior nursing and administrator staff, even business office people, and a lot of new people coming into the industry. I've run into a lot of them. I did a boot camp here for the California Association on finances, which was a lot of fun, but a lot of new people. Some of them coming from outside of the healthcare industry, some of them coming from the healthcare industry, or from education, where they had a lot of education, say on the physician side or in the hospital side, because there really is no education programs in colleges and universities for our type of a setting. Let's talk a little bit about, what's going on there and the need for mentoring of our leadership and, development of our future leaders here.
Yeah, I think the overall staffing shortage issue that we're seeing and this leadership challenge are interrelated.
Yeah,
I think that they are separate to some degree, but I think they are related. I think that this is a problem that has been long in coming, and I think the pandemic obviously really push things a lot faster because of the resignations we've seen, the decisions by people to just throw up their hands and retire. And I think that has led to both an overall staff shortage, but I think we are also seeing a leadership shortage in terms of, where are the next generation of administrators and CEOs of surgery centers going to come from? And are they going to have the breadth of knowledge and training and experience they need in order to succeed and to make sure that our ASCs continue to provide the great efficiencies, the great patient safety, and the great quality that we have come to expect. So, your boot camps, I think our administrator development program is a way to try and address that, so that we can find either new administrators or people who want to become administrators and give them the training and tools so that they can, lead a surgery center and help a surgery center succeed, today and into the future. One of the things that our program focuses on is basically connecting a new administrator or a soon-to-be administrator, a mentee, with a mentor, someone with experience in the ASC setting, a proven record of success that they can turn to, outside of the classroom, outside of the training and sessions, to ask questions of and to get, in
a non-threatening way,
in a very non-threatening way, to be able to, ask the stupid question, right? Yeah. Of course, there are no stupid questions, but sometimes people feel like I think I probably people expect that I know this, and I'll just muddle my way through. Yeah. Where now they have a trusted, person they can turn to, ask that question, get the answer, and then obviously, apply that, in their surgery center. So I think it's something that, we have to spend a lot of time and attention on. Right. It's something that's, I think the initial reviews from our program, and I'm sure you're seeing the same with yours, is really positive, and it's something that I think we're going to grow over time, because I think this is a problem that's not going to go away.
Right. And what I love about your program too is that one-on-one mentoring also assists, not only to have somebody ask the questions for, but also to introduce people to other individuals in the industry. And so I remember the first time I came 32 years ago to the first ASCA conference. I didn't know anybody, but I have no problem going up and introducing myself to any people. Not everybody is that way, and I think this provides a great opportunity during conferences. Just
exactly that, because part of our program does involve them coming to our in-person meetings and with that mentor, and then meeting people, and obviously getting the experience of that being live in an ASC environment. We also, though, recognize for some people that's just not going to work. So actually this year we're developing a virtual version of that program. You're still going to have one-on-ones with a mentor and be able to, Zoom with them or potentially meet them in person if you're in your area, but allow you to get that education and training in a virtual format rather than in person, if that just doesn't work for you. So now there's two different ways of doing it. It also creates two different opportunities during the year to start this program rather than have to wait a whole calendar year to get started. So this is something that I think is only going to grow. I very much appreciate, the ASCA volunteers that are serving as mentors, our education committee, which you've been on, to help develop this program. And I think it's one of the ways we can ensure that the ASC model not just survives, where we are in healthcare, but thrives.
Absolutely. And I think for all of our listeners out there, they need to remember that you're never alone in this industry. I mean, there are no secrets. We share our policies, we share our resources, and we share, our knowledge, through these one-on-one relationships.
I think unlike almost any other healthcare setting, the ASC is a welcoming environment.
Yeah,
when you come to any of these meetings, people are so willing to try and help out, answer questions, help each other out. We saw that our last ASCA in-person conference, the number of people that asked questions or added to the conversation during sessions was really great to see. And the thing I always just remark upon, because I think we take it for granted, the ASC community is the most optimistic community in the healthcare space.
Isn't that true?
It is. If you spend times in other settings, there's so much negativity and so much focusing on what's going wrong. The ASC setting, from the physician leaders to the administrators to the clinical staff to everyone, they just have a more optimistic view of where things are heading. I mean, obviously we have plenty of challenges, plenty of problems to overcome. So I'm not trying to just blue sky this, but overall, I think because we figured out a better way to provide healthcare and to make patients not only get the healthcare they need, but do it in a safe way and in a patient-friendly way, that just leads to a more optimistic view of where things are. And so I just kudos to everyone listening out there in the ASC community, because you've made this the best place to work in the healthcare sphere. And
lastly, I promise this is last, the importance of becoming a member of ASCA and, of course, becoming a member of CASA. Here we are at the CASA conference, and the importance of being members of both.
Yeah, look, there are personal benefits to it, because then, as we've been talking about, you get to interact with other people that are experiencing the same problems and challenges you are. So it's going to allow you to do a better job in your work and obviously just access better information. The ability to get the education and training to stay at the top of your field that you can only get at an ASC conference, whether it's a state conference like CASA or any of the ASCA meetings or any of our online virtual offerings. And then thirdly, the support you give financially by, paying your registration fee for a conference and being a member, your membership dues are the only way that we can, support the ASC community, that we can afford to hire people to advocate for ASCs in Washington or in state capitals, to put on the education and training, to be able to communicate, what the ASC model is doing to the larger world, whether it's the healthcare media or policymakers or payers. So every dollar that you give to ASCA or your state association is being turned around to support the healthcare model that you're working in, to make your life easier and to make sure that your patients get the care they need.
Absolutely. As always, Bill, thank you so much. Thank you for everything you do for the industry. Obviously, we got a great story. That's why I think we're so optimistic. We have a great story post-pandemic.
Well, thank you, John. You have been a tremendous advocate in the ASC community. The education you provide, particularly on financial issues, is just been outstanding. You've been a great friend to ASCA and to me, and I thank you for this opportunity to spend a few minutes with you and your listeners.
Always. Thank you so much.
All right.
In this segment, we provide an update on upcoming topics for the podcast, our upcoming virtual conferences, and any upcoming speaking arrangements for John and his staff, and other events in the ASC industry.
So the next event that's coming up is the 2022 Northeast ASC Conference presented by the Massachusetts Association of Ambulatory Surgery Centers. And that's going to be on October 21st, 2022 at the Massachusetts Medical Society Conference Center in Waltham, Massachusetts. Lori Rodericks and I will both be speaking at that conference. I've been there before. I always enjoy the time with, and it's a one-day conference, pretty easy to get to, and really encourage you to go to the Massachusetts ASC Association website to sign up today.
And the ASC Director of Nursing Boot Camp for nursing leaders in the ambulatory surgery setting. Like all of our industry-leading boot camps, the Director of Nursing Boot Camp includes reading materials, virtual mentoring consultations, and an intensive 4-day virtual conference to be presented October 25th through the 28th, 2022.
And then I'm going to be going on to the Washington Ambulatory Surgery Center Association's 2022 Annual Education Conference and Trade Show, which will be held November 2nd and 3rd, 2022 at the Tulalip Resort and Spa in Tulalip, Washington. I just like saying Tulalip.
I do too.
I hope I'm pronouncing it properly. And I will be doing a session there and also hopefully recording a special episode.
And the ASC Administrators Boot Camp for administrators and ASCs and those that are looking to become CASC certified. The next boot camp will be on January 24th to the 27th, 2023. It just took me a minute. I said 2023.
No,
it's coming right up. Oh, my gosh. Yeah.
And ASCA 2023 Winter Seminar is January 12th through 14th, and that's going to be at Caesars Palace in Las Vegas, Nevada, and I will be there. I can't remember what I'm talking about. I think it's finance this time. And we always have a lot of fun in Las Vegas. And I know everybody says that people go to Las Vegas and don't attend the conferences. That does not happen with ASC people. It's always being very well attended.
Probably have a lot of fun after and before and surrounding
it's
it.
always any of
little extracurriculars.
Yeah, any of the ASCA events are great. And it's always great getting to see our friends again there. So, obviously, if you're there, look us up and, grab us. Sometimes we grab people that listen to our podcast and just ask them a couple quick questions for the podcast. So we'd love to do that with you too if you're interested.
Also, don't forget about our recorded events. They're all available on ascpodcast.com. We have the Credentialing Conference, the Conditions for Coverage Conference, the Medical Director Conference. We have the Director of Nursing and an Administrator's Boot Camp, both self-paced versions that you can access there.
Yeah, so if you don't have the time to actually do the virtual conference, you can do the self-paced version. It's not as popular, obviously, as the live versions, and you get a lot of the same benefits. You get all the same benefits of it. But what's nice is with the live version, you don't actually have to attend it. You just get recordings of it later. But please do attend it because it is so much more fun.
Yeah, and then you can throw out questions that
are pertinent to you. And I do want to remind everybody to become a patron member of the podcast. The patron member program, which is also known as ASC Central, is an exclusive membership website that provides a one-stop ASC regulatory and accreditation compliance, operations, and financial management resource for busy administrators, nurse managers, and business office managers. And the various resources that are included are virtual conferences, links to various important websites, example policies and procedures and forms, example drills, and discounts and services and books and access to the AEU credits. And probably the most important thing is that weekly drop-in session that we keep talking about where we sit down every Saturday morning, it is right now at 10 o'clock Eastern Daylight Time, and just talk about whatever is important to the people that are joining us. And we have a good 10, 12, 15 people almost every single weekend, and the number has been growing, hasn't it, Sue, recently as more and more people have discovered this thing. So, and membership helps to defray the costs of producing the podcast, including our research staff, our travel costs to conferences, equipment costs, and production costs, which, just like with everything else going on in the economy right now, keep going up. So for more information, you can visit ascpodcast.com. And that's it for this episode of the ASC Podcast with John Goehle. And please spread the word about our podcast with your friends and colleagues, and do us the honor of hitting the subscribe button. The sound editor for this episode is Susan Cronkite. Executive producer is John Goehle. Research assistance is provided by the team over at Ambulatory Healthcare Strategies, including Susan Cronkite, Jenna Alvarez, Judy D'Ambrosio, Alex Borneman, Zach Calritis, Amy Durbano, Lori Rodericks, Ann Geyer, Kathy Foti, and Donna Macchio. Music is provided by Media Sushi and Mike Noah, and the ASC Podcast with John Goehle is hosted on Podbean and is available on all major podcast channels.
This episode of the ASC Podcast with John Goehle is sponsored by Surgical Information Systems, Trivalence, and Ambulatory Healthcare Strategies. Surgical Information Systems provides cutting-edge information solutions for surgery providers. Trivalence offers a comprehensive next-generation ASC solution that optimizes payment and supply chain performance, enabling actionable insights. Ambulatory Healthcare Strategies is the nation's leading regulatory and accreditation compliance resource for ambulatory surgery centers. For more information about our sponsors, visit our website at ascpodcast.com. This podcast is an educational and operational tool and is not intended to be a comprehensive resource for all rules, regulations, and standards that an ambulatory surgery center must meet. The advice provided should not be considered as, nor does it constitute, legal advice or opinion. When reviewing specific situations involving legal and regulatory issues, attorneys and other professionals should be consulted. This has been a production of Eden Group Development. All rights are reserved. If you are interested in advertising or sponsoring the ASC Podcast with John Goehle, please email us at info@ascpodcast.com. We would love to hear your questions and comments. Please email us at comments@ascpodcast.com.